Hi, good afternoon, everyone. Thank you so much for having me here. It's a pleasure and privilege to speak to you all. I'm going to be talking about some work that I've done alongside Dr. Claire Stewart, who's the lead for this project, and Piri Kolithas, a student from King's College London. And I'm a student representing Manchester University today. So we've been working on this project for about a year or two. There's a few kind of aspects to it that I'm going to try and summarize in this quick presentation. Firstly, the kind of evidence base behind what we've done. So I'm going to talk a little bit about the literature. Secondly, the kind of initial work that we've done trialing these tools in a child protection setting. And then thirdly, how that relates more widely into general pediatric settings and looking after all children. And how we, as medical students and doctors and allied health professionals, communicate with our patients. So yeah, hopefully you guys will enjoy this. Sorry, it's the first talk after lunch, so hopefully everyone can stay awake. So yeah, I want to start this talk by putting you all in a situation that you maybe haven't been in before, and imagining that you're not sat comfortably either at home on Zoom or in a nice chair, and that instead you were sat right here next to me, and you felt like the whole world was watching you, and I sat you down and said, "Hi, I'm one of the doctors. How are you today?" Would you feel comfortable telling me how you were today? Is that something that you think you would enjoy? Even as an adult, I won't ask how long ago it was. Some of you might have been an 8 or 9-year-old that would have been sat there next to us in clinic. So just imagine being in that office. You don't know the doctor. You don't really know why you're there. You've perhaps been dragged there by your parent, a police officer, a social worker, and you've been told you need to speak to this doctor. It's not a very nice environment, and it's something that happens every day in our clinics in the UK. And then imagine that you've got communication difficulties on top of just being a normal child who's, shy. Of course, you're not going to want to talk to me. Of course, I'm not going to be able to hear what you're saying. So a lot of the work that we're doing is about how do we break down those barriers and teach medical students and doctors to hear those children better and create an environment that we know from the evidence base is more pleasant for them and hear what they need to tell us. So what is the voice of a child? Just to kind of give some definitions first. So the voice of a child is what the children say, but it's not only that, it's also their behaviors as a whole. So for some children who are maybe pre-verbal or non-verbal, their voice can be demonstrated through the way they act or things that they point to. And it's about creating an environment in which children are comfortable to kind of display that. And then what is AAC, which we're going to be talking a little about today, is augmented and alternative communication. It's basically about how the augmented part is about helping make communications clearer. And then the alternative part is about different ways that we can do that. And I will talk a little bit about some of the ones that we've been using. Communication support, such as AAC, is for all children, not just the children that I've kind of listed on the screen. It might not benefit all children, but it's something that can be available. It's something that we now have available in our child protection clinics, and it might just be sat on the table, and it will be at the discretion of the doctor as to whether or not they feel it is needed in this consultation. You might get a child who comes running in and screaming and shouting at you and will tell you everything you need to know. They don't need these tools like this. But you might also get a child, like on the previous slide, who's just hiding behind their parent's leg. They're the ones that will maybe benefit a bit more from this. So it's about giving us as professionals the kind of clinical intuition to know when to use it. And yeah, so I will just say, so this number 12, this is the United Nations Charter of Human Rights for Children. It is a respect for children's views is built into everything we do, and children must be heard and their view must be heard in their care. So I'm going to talk a little bit more about the UN Convention and some of our other duties as UK doctors. At least that's where we've kind of been trialing this. But I'm sure in every different country there will be different acts, etc., that are relevant. It is incredibly clear in UK law that the centrality of the child's voice must be heard in all safeguarding procedures to do with children, and our general medical guidance, General Medical Council guidelines make it incredibly clear for all doctors that we must hear the voice of the child in all that we do. It's become well established in the Children's Act and through guidance from the Royal College of Speech and Language and the Royal College of Paediatrics and Child Health that visual means of communication alongside talking make a huge difference to them, and how much more important it is that we incorporate that into our practice. We've had a few reports published recently in the last few years about what happens when this goes wrong, highlighting, you know, the things that go wrong. I don't want to go too much into it, but there's some serious case reviews where children have died because it's been that they haven't been heard properly and things have not been explored. The NSPCC highlights, they're this kind of charity organisation that represents children's views in the UK. They highlight lots of barriers and give us lots of suggestions for ways to do that, such as not only attempting to hear a child's voice when an incident occurs, such as in a child protection proceeding, but in all interactions we have with children, whether it's through school teachers, general practitioner, family medicine doctors, hearing the child's voice before an incident happens so that we can kind of see what the change is. We've kind of found that a lot of focus on communications between doctors and a paediatric consultation is to do with the relationship between the doctor and the parent, not the doctor and the child. So a lot of the work and a lot of the findings that we found are that we need to kind of move away from that. And as the first one shows, which is from our CQC, the child should be seen and heard, not the parent. Well, as well as the parent, obviously. So coming to the literature on this subject, we did a literature review and we essentially identified an evidence practice gap. So we searched these two main databases which cover most medical and allied health areas of research. We found over 20,000 papers on our initial search highlighting the benefit of alternative communication with children and young people. Now that was in a general context, and most of these papers were published by speech and language therapy experts and nursing experts, social care experts. When we refined our search to go down into a pediatric clinical context, we only found 4 papers evaluating alternative communication tools, and that's in a clinical conversation between a pediatric doctor and a child. So those 20,000 papers show us in the literature the benefit of it, but it's not been translated yet, unfortunately, into pediatric practice. So these are the 4 papers that we found. I'll put the references for them at the end that actually include clinical conversations. And out of those 4, they're not all particularly relevant, but they do use alternative communication with children. So we know that visual systems make complexity easy to navigate, not just for children, but for all of us. No matter where you traveled from for this conference, whatever airport you would have gone to, I'm almost certain that there would have been very easy signs. And even if you don't speak, even if the English language wasn't next to it, we all would have known where to go to collect our luggage, to go to our gate, to go to the toilet, to go to the smoking area. I wouldn't recommend. And in children's classrooms, there's loads of visual tools used, you know, whether it's just their timetable for the day will be highlighted with pictures. But I don't think I know that not many of our clinic rooms in paediatrics are actually like this, and not many doctors' consultations are carried out in this way, using visual tools to help the child navigate that clinical interaction. So what do we do about this? We developed what we call a child protection toolkit. We decided to kind of first do this in a child protection context because in this context, this is where the voice of the child is so important. We found that a lot of these proceedings were being relied on parents' voices, but we can't rely on a parent's voice when we're talking about child protection. So we kind of analysed how much of the child's voice are we hearing, and we defined what a child's voice means in our UK child protection proceedings, and we split it into 5 or 6 domains, which I'll show you shortly. We developed this visual toolkit in conjunction with children. our team went round 126 schools across London and spoke to them about how they wanted to communicate with doctors. We got them to draw things that they would have liked to have when they spoke to doctors, and we incorporated that into the toolkit. It's currently, I think, coming up to a year of being trialled across 26 NHS trusts across the country within our community paediatric services, and the results are looking really good. They make discussions both clinically relevant and child friendly. So that is our aim with the Child Protection Toolkit. So yeah, as I said, it's been developed with all these people, and that is what the toolkit looks like on the bottom right. It's just something that sits in the corner. Hopefully in time it will be on an iPad rather than a paper flip book. And then on the left is an image showing the trusts across the UK where it's being used in their child protection clinics. The image you can see at the top is some of the drawings that we received from the children in those schools when we gave them kind of specific categories as to how they might want to communicate their feelings. So the way we like to start our consultations, that we kind of encourage our doctors to start their consultations is with a concept called modelling, rather than like at the beginning when I sat you down and said, hello, my name is Martin, how are you today? We use this concept of modelling to try and start somewhere a little bit safer, a little bit warmer, and not ask about why they're here, but talking about maybe their favourite things. And start with a question like, would you like to look at some drawings with me? I think this slide looks really fun and I'd like to slide down it, but maybe I'm a little bit big to slide down it. What do you think you would like from this page of things? And we start somewhere safe, and hopefully that makes them feel a bit more able to talk to us. And tell us, you know, maybe they like to watch YouTube clips, and we can talk about what they like to watch on YouTube. Even if that's just for 20-30 seconds, that can make our consultations a lot easier. A lot of children perhaps feel in their life, especially children who are, you know, going through child protection proceedings for whatever reason, like they don't have any choice in life, that things happen to them and that's it. So if we can give them a bit of choice and say, here's a few different ways. Would you like to, which one of these would you like? We're going to talk a little bit about our feelings. And maybe I would point to this sad one and say, this morning I was feeling a little bit sad because I was really tired. Oh, the clicker didn't come up, but let's say I would point to one of the sad ones and say, this morning I was feeling a little bit sad, but then I had my morning coffee and I felt a bit more energy and happy to get on with my day. And then I was feeling a little bit more like this happy one. How were you feeling this morning? And then we can evolve those conversations to be, and how were you feeling at home yesterday morning? And how do you normally feel at home in the morning? And how do you feel at school? So it's about starting in a safe place and giving those children choices to tell us what ultimately we need and want to hear from them. And that's when it gets to their home life, where it becomes even more tricky for some of these children to talk to us. So again, we use the same concept of modelling to elicit a social history from children. So maybe I would point at the bedroom and say, this is an example of a bedroom. My bedroom's not as big as this, and the bed is next to the wall. I don't have an orange duvet, mine's grey. Can you tell me a bit about your bedroom? We had a clinic that I was recently sat in where we used this toolkit and we said, and this is a living room. There's two sofas here. Can you tell me a bit about, you know, we talked a little bit. And the child eventually demonstrated and pointed at the coffee table. I didn't want to say anything, but they were pointing at the coffee table. And the doctor was asking, can you tell me more about the coffee table? And we discovered, and the child told us that's where the bloody knife was. And through using images like this to communicate with children, we elicited a whole other part of this child's history, that there was domestic violence in the home that we had no idea about, and that the child didn't know about. They did know about it, but they didn't know that they needed to come in and tell us that there was domestic violence. How would an 8-year-old know that? But they can know if they see a picture of their home, that they can tell us what's going on, and then we can kind of deal with those things in a better way and alter their care plan. And that can happen for all different areas of the house. I don't think we have a picture. No, so we have a lot more pictures based on the format of our child protection proceedings, such as there'd be medications, and we had a child who pointed at the pill packet, just a generic packet of pills, and said, oh, I don't like those sweeties. And they thought that they were having sweets that were given to them by a parent. It turns out they were being forced to take medications. They didn't know how to verbalize that to us because of their age, but we can still hear that if we augment the way that we talk to them and hear their voice in a different way. So that's what we're doing, basically. So this is the results. It's hopefully you can see. So the key findings are that we found were that, so one, these augmented tools increase the confidence that children have and allow them to tell us their story and give them increased autonomy. We found that children struggle to break into conversations and that we as adults often miss the very, very subtle non-verbal cues that they give of trying to break in, and that we as adults dominate the conversation with them and their parents. We found that clinician expertise were very low, and that an attitude among clinicians was that often, this is for speech and language therapists. They're the ones that need to speak to the children and work on them speaking to them. While yes, it is the role of a speech and language therapist to help children develop their, speaking skills if they're delayed for whatever reason, we as clinicians need to be able to speak to our children, or we can't help them in the best way possible. So this diagram is from one of the London boroughs that the toolkit is being used in. And these are the categories that we split the child's voice into. So throughout the kind of 2-3 hour child protection medical assessment, we aim to cover all these different areas of life in detail. And you can see in red the number of, so upon reading the child protection reports, which are very long 30-40 page documents, you can see the amount of times that we're able to elicit child's emotions and feelings, likes and dislikes. And you can see the massive statistical significance between the references pre-intervention of using our toolkit and post-intervention of using our toolkit. Most strikingly is worries and fears, which prior to implementation were rarely elicited, but through using this alternative communication, we were able to much more frequently find out what is that child actually worried about, what are their fears in life. And they're obviously the ultimate things that we're trying to find out so that we can get them into a safer situation. And then finally, the kind of next stage of this process has been teaching, thank you so much, has been teaching those across our profession how to engage in this. So we have very recently we're only in the second stage of our pilot between Manchester University and King's College London, where we are teaching medical students right from the beginning, embedding into their curriculum, okay, how do you speak to a child? Because as I was just speaking with Professor Ahmed, they're not just small adults. They are very different, and the way you communicate with them must be different. And we found that doctors often don't know how to do that. And when a child hides behind the parent's leg, the doctor will just speak to the child. The doctor will just speak to the parent and say, okay, the child doesn't want to talk to me. But you're not going to hear their voice if you do that. And while that may be satisfactory, in a random asthma clinic or a general clinic, that's not satisfactory in child protection proceedings. And it shouldn't be satisfactory in other clinics, such as, cardiology clinics, asthma clinics. So our aim is that doctors across the profession, be it in the child protection context or be it in any other general setting, will be better trained on how to hear the voices of the children which they encounter. So we've done the teaching with these two universities, and we're hoping to roll this out to universities across the country after we publish the kind of results from these two sites. So thank you very much for listening.